Is Alex online?
Yes.
Great. Hi, Alex.
Hey everyone, excited for this talk.
Hi, everybody. Why don't we get started? We are really honored that Dr. Aufderheide is with us today. He is a professor of emergency medicine, associate chair of research affairs, and director of the NIH-funded Resuscitation Research Center in the Department of Emergency Medicine at the Medical Council of Wisconsin. He has been NIH funded for over 30 years, and he's recognized for his research and discovery in emergency cardiac care. He developed and pioneered use of out-of-hospital 12-lead ECGs. He contributed to and helped establish layperson use of AEDs, doubling survival rates from public ventricular fibrillation cardiac arrest in the US. His discoveries of the detrimental effects of excessive ventilation rates and incomplete chest recall, as well as methods to improve hemodynamics through intrathoracic pressure regulation during CPR, have shaped clinical practice nationally and internationally. And he's been instrumental in evaluating ECMO facilitated resuscitation for patients with refractory out-of-hospital cardiac arrest, transforming outcomes for this patient population. His career-long commitment to education and knowledge translation shaped and supported academic careers, the American Heart Association CPR training programs, resuscitation guidelines, best clinical practice, and the Institute of Medicine report on cardiac arrest. Please join me in welcoming Dr. Aufderheide.
Well, thank you for that overly generous introduction, Mary, but greatly appreciated. We were talking before we kind of went live. I've been involved with the CPR Foundation, a variety of other organizations, AHA, and so forth, and was a strong proponent of getting a sixth step to the links in the chain of survival. And it's such a thrill for me to be here today at a time when that sixth link is now finally getting some traction. And it's a thrill to be a part of that and a thrill for me to be here. So thanks so much for having me. Mary asked me to give a talk, and I thought I would talk on ECMO facilitated resuscitation for cardiac arrest. It is an emerging paradigm. You'll probably hear about it. So, and I've been involved with it for quite some time. And I thought it would be maybe a good start-off topic for the group. So we'll jump right in. This is my disclosure information. Lots of stuff on this slide, but I think the main thing is that for you to know is that I've received NIH funding for several ECMO facilitated resuscitation research projects. I don't have any interest in any device or company. I do a lot of company sponsored research, but they're all unrestricted grants, and I do a lot of volunteer work as shown there. So I think probably most of you know this already, but cardiac arrest is a huge public health problem. There's over 400,000 out-of-hospital cardiac arrests each year in the United States. And our overall survival rate is around 7 to 10%, depending on where you live, which results in 372,000 deaths each year in the United States. It is the third leading cause of death. The reason that I bring this up is that we are making progress, but we're making very slow progress. Probably 10, 20 years ago, we were at 3, 4, 5%. And we've pushed that up now to around 10%. But many of us as investigators are getting frustrated with that slow progress. And we really want to move the needle on survival and a high quality of life following survival. And if we want to do that, we have to think outside the box. If we keep on doing what we've always done, we'll keep on getting what we always got. So thinking outside the box is the topic of today's talk. ECMO facilitated resuscitation. So ECMO, what is it? How does it work? How is it applied? Now, the vision for placing cardiac arrest patients on ECMO was the vision of this person, Dimitri Anopoulos. I've been working with Dimitri for a long time and was actually a mentor to him when he was a resident. And it has been a privilege to be an integral part of this research team. So with Dimitri's vision, I'm going to be talking about the placement of patients with VF or ventricular fibrillation cardiac arrest on ECMO facilitated resuscitation. Just for a baseline, there are 3 different kinds of cardiac arrest. There's flatline that we kind of see on the TV a lot. There is pulseless electrical activity, which the heart doesn't beat, but looks like it has a normal rhythm. And then there's kind of the quivering heart, like ventricular fibrillation. That's what ventricular fibrillation is. The heart doesn't beat, but just kind of quivers. It is the cardiac arrest rhythm that responds to a shock, the defibrillation. And that's what we also see on a television. And as it turns out, about a third of ventricular fibrillation cardiac arrests respond to a shock and the treatment that we give with basic standard care. 66% of ventricular fibrillation patients do not respond. They don't respond to shocks, and they don't respond to anything that we do currently as a standard of care. So shock, 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 no response. You put in an IV, you give epinephrine, you give lidocaine, more shocks, and 45 minutes later, there's still nothing, and the patient is declared dead. That patient population for VF is called refractory. So this is a patient population that before we started essentially had a 100% death rate. Very, very few patients survived in this refractory VF population. And it was Dimitri's vision to take this population and attempt to salvage these patients through ECMO facilitated resuscitation. So I'm going to talk about the Minnesota Mobile Resuscitation Consortium ECMO program, our first observational case series, the discovery of the cause of being refractory, why these patients don't respond to what we do normally, our first randomized trial, and some insights that we've had as a result of doing this, and the vision we have for the future. So what is ECMO? Well, it's a long medical term, extracorporeal membrane oxygenation. But if you break it down, it is a long term that simply describes itself. It is oxygenation of blood through a membrane outside the body, extracorporeal. And most of us know it as heart-lung bypass. In order to do a coronary artery bypass surgery, which is a pretty standard surgical procedure these days, the heart must be stopped. And in order to be able to accomplish that surgery, they're placed on ECMO or heart-lung bypass. ECMO itself is a very flexible treatment, and it functions in 2 distinct different ways. One way it can function is simply as the lungs. It pulls blood out of the body, it removes carbon dioxide, returns oxygenated blood back into the body, and just functions like the lung would normally function. Another way that ECMO can work is both heart and lung. And in that case, it removes blood from the body, takes out the carbon dioxide, puts in oxygen, and returns the blood, oxygenated blood, back to the body with a sustained blood pressure because the heart is not beating. And it is that function that it's used for cardiac arrest. It's important to understand that ECMO does not treat or cure any disease. However, what it can do is sustain life when the body temporarily can't provide enough oxygen or blood pressure. So it sustains life while the body resolves the problem that caused it in the first place. So this is a schematic of one of the ways that ECMO works, called VV ECMO, or vein-to-vein ECMO, and that's when ECMO works as a lung. You pull blood out of the vein, oxygenate it, and then place it back into the vein, and no blood pressure is provided because the heart is beating normally. The other way that ECMO is used, like it is in cardiac arrest, is as both the heart and the lungs. In this case, blood is removed from the vein, oxygenated, but returned to an artery, large artery in the upper leg, the femoral artery, and it's brought back to the body in such a way that a blood pressure is restored and maintained, as well as blood flow throughout the whole body. That's VA ECMO, and that's what is used in cardiac arrest. So the diseases or conditions that ECMO can be used in, the one that we probably all know most is COVID-19. Many patients were saved when their lungs could not oxygenate blood from COVID-19, and their body was sustained until it resolved the lung problem, and then were taken off ECMO. Other conditions where ECMO functioning as a lung works very well is in blood clots to the lung or pulmonary embolism, devastating viruses like the hantavirus, severe pneumonia, or any respiratory failure condition. In terms of heart-lung bypass, the standard that we all know a lot about is just simply coronary artery bypass surgery, but also used in heart failure, post-heart transplant, when the transplanted heart doesn't beat well enough to be able to sustain life, life-threatening infections like sepsis and septic shock, and then also now in cardiac arrest. Placing ECMO is not a simple procedure. It is a sophisticated and complex procedure to start and as well to maintain. And only a skilled physician with considerable experience can place ECMO. Now, I'm part of Dimitri's team, but I do not place ECMO. I would need to be trained by him and certified, and then do it a lot every single day. So I have a much different role on the research team. I don't place ECMO, but it requires sophistication and a lot of experience. The catheters are large, and the ones that go in the artery can be as large as your finger. And there are some risks to the procedure. There can be life-threatening bleeding, blood clots, infection, because it's a large artery and a large vessel in the upper leg. Sometimes it can reduce the amount of blood flowing to the leg and can cause ischemia to the leg. There are a variety of different risks. So placing a patient on ECMO must be weighed. The risks of that need to be weighed against the risks of the disease. And in general, for cardiac arrest, the risks of ECMO are considered very reasonable when compared with the risks of death from cardiac arrest. Well, how do you implement an effective program? Now, remember that placement of ECMO really provides no survival benefit, immediate survival benefit to the patient. It doesn't treat anything, but it just maintains life and buys time while you provide other life-saving interventions. So it's the quality of the comprehensive ECMO program that ultimately provides a survival benefit. And at Minnesota, we have identified important components necessary to provide that survival benefit to patients. You need strict EMS protocols, accurate identification and rapid transport of patients from the out of hospital setting. Probably the most important is to minimize the time from the 911 call to when you turn the ECMO machine on. And we'll talk a little bit about the logistics of doing that. You need capable ECMO cannulating physicians. Patients should go to coronary angiography immediately and fix any blocked arteries or heart attacks that are occurring. And important is sophisticated and dedicated intensive care unit care afterwards. There's been different ways that this has been used for cardiac arrest. Probably the people who have the most experience with this are the Japanese. And this is a cultural issue because in Japan, no one can be declared dead in the out-of-hospital setting, and they have to have a physician declare death. So in Japan, EMS goes to the scene, does CPR, and when they fail in the resuscitation efforts, after a long time, they are then placed in the ambulance, transported to the hospital for the declaration of death by the doctor. Well, over the years, some physicians in Japan have said, you know, maybe this person is salvageable if I place them on ECMO. And so in Japan, they place them on ECMO very, very late. And surprisingly, despite that, they have a survival rate of about 15 to 18%. Another approach has been an approach in Paris. So the Paris SAMU program, again, is based on their cultural philosophy. In Paris, they have intensive care unit ambulances that have all the capabilities of an ICU in the hospital, and they have a doctor on board. So they don't have a lot of them driving around Paris, but they have a small number, and they can go to the scene and provide sophisticated hospital care at the scene. So many years ago, they started an ECMO program in Paris. Again, their transport or their arrival times are very, very late, and they have not been able to show a substantial difference in high quality survival compared to standard CPR, about 8 versus 9% with this program, but that has been their approach. A third study that has just come out recently is a study that was done in Europe where they didn't implement any program at all. They just said, well, we've got some ECMO machines in the hospital, and once in a while a CPR patient comes in and they're still doing CPR, we'll put them on ECMO and see if that is better than what we usually do. And no surprise, that was also too late to do it. And there was no difference in outcome with that approach. So fast forward to the Minnesota Mobile Resuscitation Consortium program. This is a different program because it was started and structured as a community-wide program from inception. It has strict EMS protocols, lots of practice by the EMS, accurate identification of eligible patients, very early and rapid mobilization to an ECMO center, a simplified process of mobilizing the ECMO cannulation team, a small group of physicians that actually cannulate. There actually are just Dimitri Yiannopoulos, Jason Bartos, and one other doctor that have cannulated all these patients for the past 15 years in Minneapolis, St. Paul. But the value to that is that each physician has had high volume, lots of experience, consistent approach, and very low complications as a result. Further, once they are cannulated, they are transported to a single centralized intensive care unit where the same docs who cannulated continue to care for them in the hospital throughout their entire hospitalization until hospital discharge. So there is complete continuity of care from cannulation to hospital discharge by the same physicians. And it has comprehensive data collection, continuous quality improvement, and benchmarking and review of all cases. So this is an algorithm of their program. In the upper left, you can see identified patients by the EMS. They make a single call to a central dispatcher. Central dispatcher notifies the ECMO cannulation hospital's ER that a patient is coming, and at the same time mobilizes the cannulation team. Cannulation team rapidly comes to the hospital, usually before the ambulance arrives, and they are cannulated in the emergency department. Following cannulation, they go immediately to the cath lab for coronary angiography and fixing any blocked arteries in the heart. And then all patients are then transported to a single centralized ECMO intensive care unit where the same cannulating doctors continue to care for them. So how do they do this? Well, all the cannulating docs have a rapid response vehicle. And I've traveled in these. It's a wild ride, I can tell you. But it is a very, very effective way to rapidly get across town. We've got really from Minneapolis to St. Paul in about 8 minutes. But it requires training and certification to have one of these cars and drive one of these cars. And the entire ECMO team is certified. And they take it home at night, they park it in their driveway, and can respond within about 8-9 minutes anywhere in the Minneapolis-St. Paul area as a result. This is the structure, and I just show this to show you that it is a very organized structure. There's a board of directors, a president, a medical director, program director, and so forth. And the cannulation hospitals are very strategically selected. There's one on the east side, one on the northwest side, one on the southwest side of Minneapolis and St. Paul, with the intensive care unit, University of Minnesota, directly in the middle. So the catchment area of this entire program covers more than the metropolitan area of Minneapolis and St. Paul as a result. So after the development of this program, which took a long time, probably 8 or more years, with lots of negotiation from hospitals, from EMS systems, from intensive care unit, from hospital administrators, and so forth, we finally got started and published our first 3-month experience. Patients are 18 to 75, primary VF cardiac arrest with 3 failed shocks. Their body habitus has to fit a Lucas device, mechanical CPR device, for transport to the hospital, and an estimated transport time by the paramedic of less than 30 minutes. No, these are not nursing home patients. They are not DNR patients, no terminal illness, no trauma, and no primary pulseless electrical activity or flatline cardiac arrest, and no bleeding. So with our first experience was just small, it was 18 patients. We were asking ourselves, does this work? Well, after the first 18 patients, we determined first that it was feasible, and we had a 50% normal survival rate out of the 18 patients, and no significant ECMO complications. And basically, from this small experience said, well, there looks like there's a signal of benefit here. Let's continue. This seems to be working. So we went on for the next year and had a total of 72 transported patients, 62 of which met eligibility criteria, and made a significant discovery. In cathing all these patients and looking at their coronary arteries, 84% had severe complex coronary artery disease with near total occlusion of all blood flow to the heart. The classic example, there are 2 arteries that supply the entire heart with blood. And the classic example we would see is that the entire right coronary artery system was occluded chronically, and that the patient had a proximal left main artery blood clot. And when you did the coronary angiography, there was the absence of all blood flow to the heart. Well, no wonder they're refractory. These patients are reasonably young, 56 to 58 years of age. And shockingly, 90% never knew they had coronary artery disease. And the first symptom of heart disease was sudden death. Overall, we had a 45% functionally favorable survival rate. We compared it to a retrospective control group with standard care from the Resuscitation Outcomes Consortium data. It wasn't a perfect control, but pretty close. And it was at least 3 times better than the current standard of care. So with that experience, we got permission from the Food and Drug Administration to do the ARREST trial. Now, the ARREST trial is a randomized controlled clinical trial, or otherwise known as an RCT, and the kind of trial that is considered as a definitive trial, because you're randomizing patients to one treatment versus another, and it is the most definitive way to answer a question of which one is better. It was a phase 2 single center intention to treat safety and efficacy study, same entry criteria that I previously went over. The outcomes were assessed by people who were blinded to which treatment the patient got. The ICU was protocolized, and the trial was stopped early by the National Heart, Lung, and Blood Institute after a unanimous recommendation by the Independent Data Safety Monitoring Board following the first 30 patients, because the difference in survival of ECMO was so great that it exceeded our stopping criteria early on in the study. That is, there was a 98.6% chance that the improved outcome from ECMO was due to ECMO and not due to chance. Overall, the survival rate with near normal survival rate was 43%. And only one patient with the standard group survived to hospital discharge. Unfortunately, that person had devastating neurologic injury and died about 6 weeks later in a full care facility. All the survivors for ECMO were really normal at 6 months. And the difference in cumulative survival rate was so significant at 0.0001, again, that the Data Safety Monitoring Board stopped the study early because of that benefit. And we published that in the Lancet, and subsequently to that, we pooled our data with another study that was performed in Europe, and demonstrated essentially the same thing, that there was a very significant cumulative survival benefit of ECMO compared with standard care. So at this point, we asked, well, what have we learned? Well, what we've learned from this experience is that these patients are treatable and salvageable, and that they are reasonably young, average age of 58. And by the way, 14% are less than 39 years of age. The youngest we have put on ECMO is 16. And these people are in the prime of their lives with every reasonable expectation for continued quality and duration of life. We've had 2 physicians placed on ECMO. One was an interventional cardiologist. Both are in clinical practice, back at work, back with their families. The difference in survival rate in our experience, depending on how you model it, is 20 to 40 times better than the current standard of care. And this approach does not result in more patients with severe neurologic deficit. And in fact, it's half of what the current standard of care is. With poor survival with ECMO is 3%, and it's almost 6% with standard of care. Further, we have found the cause. And the cause is, as I mentioned, is severe coronary artery disease with near total occlusion of all blood flow to the heart. Now, as such, continued treatment of this patient population with the current standard of care is unlikely to ever significantly move the needle, which is what we're after. We want higher survival rates. But if we continue to use standard of care in this patient population, now that we know what the cause is, it will never improve survival without addressing reversal of that cause. This is a standard concept in medicine. You don't treat cancer with antibiotics. And you don't because that's not the cause, right? Well, now we know the cause and we have a treatment. So I wanted to show this slide and walk you through this a little bit because it is insightful. On the horizontal line of this graph is duration of professional CPR, with 0 minutes all the way up to over 1.5 hours on the far right. Can you see my arrow? No? Okay. On the vertical axis is neurologically intact survival rate. Okay, so the taller the bar, the higher the survival. Now, the orange bars are standard care, and the blue bars are our experience with ECMO. So the first thing you can see with standard care is that there is a loss of survival rate for each 10 minutes to 40 minutes, and that nobody survives after 40 minutes with standard care. It's 0. Our ECMO survival starts at 30 minutes. It declines similarly out to 60 minutes, but it doesn't go to 0 like standard care. And we continue to have about a 20%, 15 to 20% routine survival rate out to 1.5 hours and more. What we would like to do also is look at this bar at 30 minutes, the blue bar at 30 minutes. You can see from our experience that if we can get a patient on ECMO within a half hour of the 911 call, we have 100% normal survival. So that's our new goal. Our new goal is to get as many patients as we possibly can on ECMO within 30 minutes of a 911 call. You might imagine what a logistical challenge that is. And there are a number of ways that we're trying to tackle this problem. One of them is this. We know we can save 100% of our patients if we can get them on within 30 minutes. And so we want to take all those blue bars in the upper right and push them to the left as far as we can. And we also know that every 10 minutes that we can save increases our survival rate by 15 to 25%. So even 10 minutes makes a huge difference in outcome for this patient population. So we received funding and have developed the first of its kind mobile ambulance, shown on the left lower picture, with ECMO and a cardiac catheterization laboratory in the back, and all the facilities we need to treat a patient right at their front door or as intercepted with the ambulance in order to maximize the number of people that we can treat within 30 minutes. We've now treated about 6 to 8 patients with this approach, and it is very, very effective. So in summary, ECMO facilitated resuscitation is really a new emerging paradigm for the treatment of cardiac arrest, particularly refractory cardiac arrest. The MMRC, it has the highest functionally favorable survival rate in the world using this approach. It's a high quality program. It's community-wide. It is economically sustainable and could serve as a potential model for other communities. What the program has shown to date is that it can result in a 45% functionally favorable survival rate, or roughly 6.5 times higher survival rate than our current standard of care. It can be provided in a sustained manner to an entire metropolitan area. And if it's widely applied with the same high quality, it could result in over 30,000 more cardiac arrest survivors per year in the United States, and could increase our overall national survival rate from the current 7% to close to 20%, or 1 out of 5 nationally. We've identified the cause, which is near total occlusion of all blood flow to the heart from severe coronary artery disease. And we need to recognize this and recognize that we need to address reversal of that now known underlying cause. The generalizability of this approach to other communities, however, has not yet been demonstrated. And a lot of our efforts now are to make this program applicable in other communities. We're putting together standard operating procedures, procedure manuals, contracts, things that another community could pick up and adopt to make their application of this a lot easier than ours was, and make it more generalizable to other communities. So despite this, ECMO facilitated resuscitation, I would submit for your consideration, holds significant promise to transform survival rates from cardiac arrest in the future. So with that, I'll stop. And Mary, I don't know if people have questions. I'd be happy to answer them.
Thank you, Dr. Aufderheide. This was exceptional and really learned so much. Typically at this phase, we invite participants to either use the raise the hand function, or if you can also send in the chat your question either to the group, or you can send it to me individually if you want to stay private. I see that Francesco has a question already, so we'll start with you, Francesco. Thanks.
Yeah, thank you, Tom. That was very comprehensive, and I think when I read that my return of spontaneous circulation took 29 minutes, and obviously what you're talking about is time critical. I was fortunate that playing football in England, I had people that they knew how to do CPR and had the air ambulance, but obviously I didn't go through what you're talking about. But let's just say that, you talked about the survival rate for every 10 minutes, but look at it the other way. Would there be certain patients where CPR wasn't undertaken immediately, where, cognitive impairments may have occurred, although, it's about the quality of life in that? Is there some point where, if you kind of like looked at treatment as usual, or through this system, that you'd have to consider what would be the best treatment in the same way as you do somebody that had a heart attack? Would it be PCI or a cabbage? Curious.
Yeah, so are you asking whether you might consider ECMO to improve cognitive function?
Yes.
Yeah. Yes is the answer to that. I think. I don't think there's anything definitive, but what we have seen with our ECMO is that first, that very few people survive with bad neurologic outcome, and that most of the people who do survive are either normal or very, very close to normal, despite very prolonged periods of CPR that we're used to, like over an hour. Okay. So you might be right that there might be something to consider to provide that extra support for people to improve cognitive outcome in general. Who knows?
Yeah. Just to add, if somebody had told me after I had my quadruple heart bypass after my third heart attack that coronary arterial disease just doesn't go away because of your scarring, something may occur later in life, then I may have done something about it, or maybe I couldn't have done anything about it. But the reality is, it's about early detection and prevention. Now, I would have thought that in America, if they start screening people at a younger age, I don't know how they're going to do that with such a big population, then it wouldn't necessarily need, you know, the good services that you're providing if people undertook lifestyle changes. Thank you.
Agreed. Agreed.
I see
Thanks.
Kara with their hand up as well. Thanks so much, Francesco, for that question.
Did you call on me?
Yes. Yes.
Okay, thank you very much. Dr. Aufderheide, I wrote a note while this scheduled, and I just wanted to let you know that in July, at the end of July 2022, I experienced sudden cardiac death due to coronary artery disease, and Dr. Adam Ubert and Dr. Cinquagrani and Dr. Gitter at the Medical College of Wisconsin Frederick Hospital put me on ECMO for 6 days, and I'm pretty normal. And I skied 2 weeks ago in Vail, Colorado for 5 days straight. So I'm a poster child for those of you in the upper Midwest who are working so hard on ECMO as a life-saving intervention. And I just thank you all.
Well, thank you so much for sharing that. I can't tell you how much that inspires me. You know, as an emergency physician, very frequently we care for patients and then transfer them to people like Mike Cinquagrani and others for continued care, but we don't get follow-up, right? So thank you for that. Made my day.
Yep, and if you ever do need a literal poster child, I will be it, I assure you.
Okay,
Thank you.
wonderful.
So we had a question come in the chat, Dr. Aufderheide, if you don't mind clarifying. It was about survival rates. So could you clarify if the survival that you were talking about is up to discharge, 6 months, or 1 year? If you guys have looked at
6 months survival. Yes, 6 months survival. And our experience is that cognitive issues as well as physical continue through 6 month period, at least the 6 month period. And most of the patients, our ECMO survivors are either normal or close to normal at 6 months.
Absolutely incredible. Yeah, thank you. I see Steve's got his hand up as well.
There, Dr. Aufderheide, it's great to see you as always. And sorry that I have to do this just to get a date to see you, but I'm from Wisconsin as well to everybody, and I'm a 3 times out of hospital survivor, as Dr. Aufderheide knows. I had a question though, since I have been engaged in this field. You mentioned a couple of times, you know, the process of getting this, how long it took and everything. And you mentioned one of the comments I wrote down was 2 doctors, 15 years, you know. My challenge with everything that we try to do is to get it into as many places as possible. And that tells me, wow, this is going to be an incredible challenge, let alone, you know, forget the ECMO truck, the cost of that. But I mean, just getting this mentality implemented. I was wondering if you could comment on your thoughts on that.
Yes. There is absolutely no question. The generalizability of this and the motivation of other centers to do what we did is questionable. And that's why what we're doing now is trying to make this simple. That is standard operating procedures, contracts with medical organizations, all of these things that we had spent so much time doing, negotiating this, negotiating that, recommending this approach versus the other approach based on our own mistakes, and better ways to efficiently implement an effective program that contains the important core components that translate to improved survival. Okay, what's happened so often is that other centers say, well, I got an ECMO machine and once in a while I get a patient, so you know, here, I'll put them on ECMO. And that sort of lackadaisical approach just doesn't work. So your point's well taken. It is it is a significant undertaking, but we're working hard to make it much easier to implement in other centers.
Thank you.
See that Michelle had wanted to talk about her ECMO experience. Go ahead, Michelle.
Thank you. In 2018, I suffered cardiac arrest at my house. Unknowing I was having a massive bilateral pulmonary embolism. I was 40 years old and they started CPR right there. I became a Jane Doe. The first hospital I was transferred to, or they took me to, was United Hospital in St. Paul. Thankfully, they bypassed the regular hospital because I probably would have died at Ridges. Then at United, I deteriorated. I believe I was on the Lucas machine. And I was transferred to Abbott ECMO. And I have made a full recovery. I would say even more than full recovery. Last year, I learned how to play the piano. I'm doing everything, traveling. I'm really, really lucky to be alive. They gave my family less than 1% chance of survival. I jumped on my trampoline this morning. I'm just so lucky. Thank you.
Well, I'll tell you, Michelle, thank you. I didn't expect to be so inspired. But all of you have inspired me. It just gives me so much energy to keep going and to keep pursuing this as long as we possibly can to improve survival. So thank you so much for your stories. They're so valuable and important.
Go ahead, Joe.
Thanks, Tom, for just a great presentation. I know offline we spoke briefly about my neighbor who's only 9 years old, who was on ECMO for 5 days after a cardiac arrest, various complications from mitral valve surgery. And my question is, in your study, your inclusion criteria, the youngest individuals you allowed in your study or took was 18. Years of age. And I'm just curious as to why that was a cutoff at 18 and not younger.
Yeah, so I mentioned that our youngest was 16. That was not on a study. That was not on a study. It was just an independent patient that came to Dimitri's attention. And of course, he, put the patient on ECMO. But that's the youngest he's done, but not part of the study and not part of the program. What's happened as a result, there are side effects of this. Dimitri gets asked a lot to place people on ECMO that, aren't within these parameters. It's like, well, maybe Dimitri can save them. Dimitri, I got this patient. Well, will you put him on ECMO for me, please? Right. So the 16-year-old was one of those types of cases, but not part of our group. 18 to 75 is really a regulatory thing. It is, the definition of an adult. If you are going to treat children, it is much more complicated initially. Generally, when you're doing new procedures and so forth, you wish to demonstrate efficacy in the adult population and then translate that to children. You don't expose children to risk as I shouldn't say as easily as you do adults, but you do adults first, and then if it looks like it has value for children, translate that to children. And that's why it's 18 years of age.
Thank you, Tom.
Certainly, though, just in general clinical practice, children are very frequently placed on ECMO, and they are because they so frequently have severe pulmonary disease. So they have a much more frequent incidence of respiratory failure from a variety of reasons. And so in clinical practice, children are placed on ECMO all the time as VV ECMO as a lung, not as a heart lung, but as a lung. It saves a lot of pediatric lives.
Any other questions or comments you have for Dr. Aufderheide? Feel free to raise your hand or send the chat.
Kerr has got his hand up, but I don't know if you've missed it or it's a legacy hand.
Oh, I had assumed that had been left up. Kara, certainly if you have more to share, feel free. Mr. Whitson. Okay, it seems like
No, yeah, nothing more to share. Must have been left up. Sorry.
no worries, no worries.
Thank you.
Well, again, I want to thank you for being here. It's wonderful to see some familiar faces and to meet others. And I can't tell you how inspired I am from your comments. Thank you so much.
Yeah, this has been quite amazing. Thank you again so much, Dr. Aufderheide, for coming to speak with us. Certainly feel free, as always, to post in CASA if you have any other questions or comments related to the talk. We're all members here, so we'll be able to see it. Mary, if there's anything else, I'll hand it over to you.
Thanks. I just wanted to thank you again, Tom. We really appreciate your expertise, and I think this has been very helpful for a lot of people on this call. So thank you very much.
Thank you.
All right. So I guess if there's no more questions or comments, we can disconnect now. Thanks again.
Thank you.
Thank you.
Thanks,
Bye.
everybody. Take care. Bye-bye.
Thank you.